All right, I think we'll go ahead and get started. I'm sure some more people will hop on. Thank you everyone for coming this morning. I'm Amanda Buckner. I'm gonna mute Ben. My name is Amanda Buckner. I really appreciate each of you showing up this morning and registering for this CE event. We're really excited to be able to put this together. So I'm the Community Relations Manager up here in Steamboat Springs. And with that, I will turn it over to Ben Court, our CEO.
Unmute. Hey, good morning, everybody. Especially Jill. Jill, it's been way too long, and it's fun to see your face on this. Let's have lunch together soon, please. It's nice to see you. I'm really glad that everybody took a couple of minutes to join this today. My very dear friend, Kristina, has come into town from California and is still tripping out about the snow because it's going to be a little squirrely up here the next couple of days. Kristina and I have been on the board of directors for NowGap together for quite some years. And NowGap is the National Association of Lesbian, Gay, Transgender, Bisexual Treatment Providers and their allies. And in addition to teaching me a great deal about how to be a part of the solution in assisting these communities, she's also just become a very dear friend over the years. So Kristina travels around the country, does a lot of talking, but also has some pretty cool and interesting day jobs with CCAPP and a consulting company. Her list of accomplishments and boards she sits on, et cetera, are extensive. I've never seen Kristina present on a webinar. I don't have any idea how her ridiculous energy is going to translate on the computer. Because she's just buckets of fun to be with. I hope that you enjoy the next hour, get a little something out of it, and I hope you get a chance to connect with Kristina after this. We'll certainly leave time for questions, but I'm gonna get out of the way and give this chair to my dear friend, Kristina.
Thank you so much, Ben. All right, so good morning, good afternoon for those, if anybody's from the East Coast, because I know that's about 3 hours ahead of us. I'm gonna go ahead and share my screen right now. All right, thanks so much. Here we go. Let me share this, and good morning. All right, so everybody should be seeing where it says clinical considerations when working with the LGBT population. Amanda, give me a thumbs up if we're good. Okay, awesome. So today I just want to say thank you so much. I really appreciate being here. Thank you, Amanda. Thank you to all the staff. You know, also Ben Court, the CEO, for bringing me aboard. Really look forward to this training today. And we're going to go ahead and get started. There's my contact information for anybody that is interested or has questions after this. Once we have this conversation, there's my email and also my cell phone as well too. Okay, so if there's any questions that come up for you and you're not sure, you know, you're like, wait a minute, you know, I need more information or whatever, you can also contact Amanda and then she can get, you know, me squared away and we can go from there. All right, so you ready? Is everybody ready? So the first thing I want to know in the chat box really quick is what you ate for dinner. Just kidding. Just what did you have for breakfast? While I go ahead and go to my next slide really quick. Really quick, where you see all those acronyms behind my name. It's also, I should have put human as well too. So it's Masters of Arts in Counseling and Psychology with an emphasis in marriage and family therapy. I have my license in alcohol and advanced drug and alcohol. I'm a drug and alcohol counselor as well, certified gang specialist, and also a CSAT, which is the certified substance, it's for sex addict, sex addiction candidate as well too. All right, so let's go ahead and get started. Just a little bit about me, because the thing is who's going to be actually training you today? Well, it's me, okay? But a little bit about me really quick. See my little daughter in the side? That's Charisma. So my name is Kristina Padilla. I go by the suffix of MX Padilla, which is pronounced Mix Padilla in my bio. One of the things is, and I'll get into that in a minute, my pronouns are she, her, and they, them. A lot of times, Your clients might go by 2 or 3 or 4 different pronouns. I go by she, her, and they, them. And as I unwrap this training, you'll understand a little bit more how to approach individuals that have more than just one pronoun, or how would you talk, if somebody in your clinical practice, even staff members have more than 1 or 2 pronouns, okay? My suffix is MX, like I said, Padilla. It came out about 4 to 5 years ago, not 45 years ago, but 4 to 5 years ago. And what it is basically, it's gender neutral suffix. Instead of saying Mr. or Mrs., I don't go by Mrs. or Mr. I go by MX, pronounced Mix Padilla. My identification is different than my sexual orientation. So my gender identification is gender fluid, my fluidity. I'm two-spirited, which I'll talk about a little bit later. I'm also Native American, Apache, Western Apache, and also Cherokee Nation. I also identify as a trans and non-binary person. I have a 5-year-old daughter named Charisma that you see on the right. That's when she was probably about 3 in a dance. And my favorite food, just in case anybody wanted to know, is cheese enchiladas if we ever hang out. Let's see, favorite song is I'm Still Standing by Elton John. I love the smell of rain and campfire. Now I love out here in Colorado, y'all know how to do it right with the snow. Also, I love to educate and teach, and I received my higher education teaching certificate from Harvard, and I'm going to Yale actually in June for a women's leadership program that they have. And one of the things I want to say to everybody today, my favorite quote, which is huge, is the expert was once a beginner. Because one of the things, we can become very expertise and very knowledgeable in the areas that we're at, but the long story short is that we begin somewhere. I remember one time that I had to put a chair together. Who knows how to put a chair together? It was like a couple years ago. I wasn't putting a chair together. Somebody else could put a chair together, but the office needed a chair and it was me and I had to do it. So was I an expert in putting a chair together? No, but the thing is I have expertise and credentials that go off the roof. But the thing is I had to begin to be a beginner. So I want to invite everybody today to be a beginner. Okay. So looking at the target audience, I'm not going to read through this whole thing, but what I will say is that all mental health clinicians, SUD, substance use disorder providers at all levels should have a training as such. Peer coaches, interventionists, support staff, public health practitioners, community-based organizations, all of the above. You look at the objectives today. We're going to go over a little bit of clinical work, more at the end about the CBT, CBFT, if we can get to it in this hour. Also stigma, and also terminology as well too about gender. So if anybody has not welcomed you to the Rainbow community, I want to welcome you. I want to welcome you because a lot of times you haven't been welcomed. And whether if you're an ally or not, they're like, well, Kristina, I'm not, I don't identify or my sexual orientation is not in the LGBT, but you're an ally. There's an A in there for ally and also asexual, which is the ACE community. Okay, so if you think that you don't belong, you are here belonging with us. You're going to learn some information today that you'll be able to take back to your practice and utilize as we go. So welcome. This is me shooting rainbows and ponies out of my wrist and welcoming you with a big hug saying welcome to the Rainbow community. Okay. All right. Permission to learn new things. This part's important because I have probably a lot of different people with different acronyms and, our little alphabet soup behind our names, including myself. But one of the things is permission to learn new things. Okay. And then I want to make it a safe zone. I travel the nation and a lot of times people say, Kristina, I don't always feel safe. But what we want to try to do is do an which is safer zone, which you want to go ahead and ask a question. I'm here for this whole hour for you. They have brought me in here to be able to answer any of your questions, also give this presentation as well too, and how important it is to be able to use this platform and also utilize me with any questions that you have. Personally, or if it's clinically, okay? So when you do go ahead and ask a question in the chat box, because at the very end, I'll go ahead and take questions and stay on if you need me a little bit longer. But for the most part, we're gonna look at it as in a lens of the best way you know how. You are actually asking a question the best way you know how. So the first thing that I want to talk about is the unhealthy impact of bullying on LGBT youth. We don't know what particular gender this person is. It appears to be somebody that's feminine and young. A lot of times we go ahead and place gender roles, force gender roles on kids, and also we force them on adults. And the thing is one of the things with kids, working with individuals, it's hard enough with just adolescence itself, but also to have people go through the chain, grow up all together, and actually go through high school and go through junior high and go through different stuff. But then there's also the stigmatic part of bullying that happens with the youth. So you see this little person right here being bullied, and this person's all to the side and just not too happy. Then you look at bullying in schools, okay? Or you could even look at it even in treatment facilities. Looking at about 8 to 10 students or clients have been harassed, verbally harassed, and 4 or 10 have been physically harassed at school. And then there's been a lot of homophobic, remarks like dyke or the F word, I'll call it, and frequently, just really derogatory means, and then you've got 80% of trans students, okay? I would actually say 95, if not more, that reported feeling unsafe, and a lot of this stuff, the youth is at risk for not only just, really bad bullying, but also smoking, dating, violence, suicide attempts, because not always do two men or two identified men, and also, their sexual orientation, the orientation is gay, want to go ahead and call the police and say, hey, you know what, this person hurt me and this is my partner, because there's been a lot of backlash, because sometimes they feel shame. Like, what is another officer that's heterosexual or presumed to be heterosexual going to go ahead and I feel maybe they might laugh at me. You know what I mean? Because I'm in love with another man. So there's been a lot of times, there's been a lot of violence with also same gender loving women and women, men and men, that has happened because it's unreported. So I would even say the statistics of unreported domestic violence and also partner violence is very high. So another thing I want to take a look at is pronouns. What's all this stuff about pronouns and why do they matter? Because a lot of people say, this particular person has these pronouns and, I only knew of he and she. Well, a lot of times when we were growing up, that's all we heard. I know that's all I heard, he, she. But the thing is they really do matter. And why they matter is it's because it's a person's identity, just like somebody's name. It's important that we take time to learn a person's pronouns than rather make assumptions about how we refer to them in conversation or even in writing. So all those clinical notes and all the different stuff that you do, and also, where it's a habit to go ahead and refer to he or she based on appearances, we're recognizing that gender is a spectrum and we cannot presume, okay, we're not placing gender on somebody. A person's gender or a person's pronouns is not based, solely on appearances because of the assumptions. Some people might ask, what are some pronoun sets and what do they mean? So when you see the set of he, him, and his, it refers to and identifies a boy or a man, but not limited to the male person, and it can be really very affirming pronoun for some people, but we can't always assume who appear to be masculine or affirm a male identity use he, him, his pronouns, because they might use she, they, z, zer, or x. You also have a pronoun set of she, her, and hers. So just similar to the he, him, his set, you can refer to them identified as a girl or woman, but also is not limited to the female identified person as well. So, that person might use other pronouns. And then you've got the they, them, and their, which a lot of people think that just showed up overnight. Well, it's been actually around since 1375. The Oxford Dictionary English, sources it all the way back. And that's a long time, 1375, in addition, it was used as a plural pronoun, they, them, and their, and basically has a rich history of the gender neutral or trans community, utilizing this particular, along with gender nonconforming, gender expansive, and individuals that are gender variant, which means they use any of the pronouns that are in front of us. Another ones that you might have not seen before is z, zer, and zer. And then at the end, it says, just use my name. If in the very beginning, you might not be like, well, I'm not sure how to approach this because of the fact that I have never seen anything but she and her pronouns and he, him pronouns. But the thing is we practice, okay? But one of the other ones that you'll see with a lot of millennials is z, zer. And what it is, it comes from the trans community and another gender neutral pronoun set. So each individual decides their pronouns best fits in their identity. We don't pronoun people. You know, we don't put them in a box. If they want to be put in a box, they'll let us know what their pronouns are and their identification and sexual orientation is. And at the end of the day, you know, looking at besides just the Z, you know, it's pronounced like the letter Z, like HIR is typically pronounced the word like here, but put a Z in front of it. So Zer, okay? And then at the end of the day, you know, a lot of times it can be very complex and fluid. So some people don't use pronouns, they just use their name. They might say, hey, you know what? I'd rather you just use my name. And, you know, a lot of times working with youth and young adults, a lot of times when I get the call from different states, they say, Kristina, you know what, I don't want to inconvenience the staff because they can't get my pronouns right. And it's really breaking up our relationship because they're doing the same thing I did in the other program. They're misgendering me, mispronouncing me. So it's very important that we practice that because you could break the therapeutic relationship with your client. And then they might not even want you to utilize them because we can't get them right, even though we're practicing to do better. You know, so a lot of times if you're not comfortable yet or you haven't practiced, just use their name until you can. And once we know, we can't not know, so we need to do better. So how do I ask for somebody's pronouns, right? So like, you're like, okay, I'm not sure about these pronouns. Well, we want to ask our, you know, allies to ask rather than assume somebody's pronouns, right? So basically you can go and say, similar to a name, we can't know the best, how to respect somebody in a conversation. So one of the things is a lot of times I say, hey, my name's Kristina Padilla. I go by the pronouns of she and they. You know, a lot of times they mirror it, but not all your clients might do that, or your staff members might do that right away. So you can also state, my name is Kristina. My pronouns are they, them, and she and her. And are there any names or pronouns? Because you're also utilizing the name as well. Are there any names and pronouns I can best respect you? And the thing is I also want to look at liability for people to, you know, you don't want to get sued. Let me tell you. One of the things throughout the United States is a lot of times you want to use what you would do for one for all. You want to discriminatory anybody like, oh, this person looks and appears to be gay just because it's stereotypical or, you know, they look like what has been put out there in society. If you ask one person that's coming in your treatment facility, you need to ask them all. Doesn't matter if you think that they're heterosexual, heteroflexible, you know, they come in with a wife and, you know, 3 children, you know, you would just still use that. And you know what? One of the things is they also could be utilizing a different name, not necessarily, or maybe that they're still, you know, maybe later they come out as they have a same gender loving or they're gay. Just because they're married and, you know, have a wife does not mean that puts them in a box. But a lot of times we do think so, you know, but looking at that part of when they first come into treatment is what, you know, what my name is and what pronouns can I best respect you by, or is there any names or pronouns I can respect you? And I'll tell you, it is very affirming when somebody says that. Okay. And it's okay if somebody doesn't want to share their pronouns right when they get there. You know, because they might have had a bad experience somewhere else, or they get mispronounced all the time and their name wrong all the time. So they might just be, it's not about us as the clinician or counselor. It might be them that they're not ready and it's not safe yet to do that. Maybe they got beat up, maybe they got raped, maybe something happened. So it's really for the clinician to take that and be like, oh, they just don't want to tell me. No, it has nothing to do with us. Remember, they're coming in with what they got and we're working with that, but sometimes we take it personal. So looking at misgendering, okay? When we look at misgendering, to misgender somebody means to use the wrong name, pronoun, or address for personal gender. So whether it happens innocent or malicious attempts, because there has been some people that say, I don't want to identify this person as, you know, which is dehumanizing, by the way, but I do not want to go ahead and say their name, or I don't want to use their pronouns, you know, and you know, they choose not to be a good ally, you know, they're just like, you know what, and invalidate that person, you know. And the thing is, unless, you know, there's a lot of questions that come up for people around this, but it's very hurtful, you know, it's very deeply hurtful and can even put a person's safety at risk. Okay. So purposely misgendering is not okay. Like just because maybe somebody's lifestyle we don't agree with, or maybe we say, you know, I don't like that person. Well, that's client harm. And also the other part is you don't want to make somebody not feel wanted, especially when you're doing clinical practices. You want to do the best care we got into when we have our scope of practice, our code of ethics for humans, period, you know, and this might be something new for us. So opening our mind and learning something like, hey, you know, it's not like a lot of times people have beliefs like, oh, I'm going to sleep with this person. That's your client. So we ain't sleeping. Plus that's an ethics complaint. How people live their lives, we're there just to help, not to judge. Okay, just like anybody coming in that, you know, was out on the street slamming dope, not to judge, to help. You know, anybody coming in snorting lines, you know what, and was a prostitute, we're not going to judge you. We're going to help you. Just like in the LGBT community, we're going to put that to the side. And sometimes this isn't for everybody. Not everybody needs to be working in this particular realm. If they're going to do harm, then help just human beings, period. Okay. So one of the things I'm going to say is when I cut my hair, and I fly all over the place, you know what I mean? A lot of times I get off the airplane and, you know, or if I'm shopping or anything, I get misgendered quite a lot, especially when I cut my hair. Well, one of the scenarios I want to say is I have a little girl named Charisma. My mom was picking me up from the airport from, I don't know, it was like a 5-day trip to Baltimore, I think, or something like that. There was a place called the Popcorn Factory, I think it was. I was waiting in line, and you know, this is like COVID time, so you know, we have our mask on us and stuff, and there's a whole like 15 people outside the door, and we're waiting for popcorn. By the way, if we ever meet, I love popcorn, caramel. I'm just saying. Okay. Anyways, for the most part, I was in line. I had my mask on me. I don't have a mask right now, but I had my mask and everything. And there was one person, and she was overworked, obviously, and she was getting everybody's popcorn orders. And like I said, it was like 10, 15 people in line. There's a person in front of me, and I was next. Well, like, once again, I have my mask on. Give me 1 second. So the clerk, the woman, goes and says to me, "Sir, I'll be right with you." Tells me, "Sir, I'll be right with you." And then I didn't say anything because, you know, I was like, oh my goodness. But if I was a client, if I was your client, 3 things could have happened. One, I could have been excited that somebody saw me. If I am a strict, like if I'm a trans person or a trans man, I could be excited. Somebody saw me. They called me Mr. You know, I don't identify as a male or the suffix Mr., but I'm just rolling you through this real quick. And being so excited that somebody saw me and me excited. I want to remind everybody I still got a mask on my face. Okay. Then the second thing is just like, oh, here we go with the misgendering again. Should I correct her? Should I not say anything? You know what? I'm not going to say nothing. Anytime I do something, I got to correct them. And then the third thing I might not feel safe because I'm outed, you know, so maybe I want to walk out, you know what I mean? Maybe I don't want to have to go through this because this happens all the time. You know, a trauma response might hit. So I was like, no, my daughter wants the popcorn. I'm going to push through it. So, and mind you, I do this all over the United States. This happens all the time. So the person leaves, it's me. And then she goes, the cashier says, "Hey, how can I help you, sir?" I was like, "Can I have," because I chose not to say anything. I was like, "Can I have the caramel and the butter in the back with the extra butter?" She's like, "Oh my God. Oh my God, I am so sorry." And like has like a historic, sorry, it's saying sorry, and oh my goodness. And I just wanted to crawl underneath the rock. I just wanted to get my popcorn and get out. And mind you, I'm very versed. I've been out for a very long time. This happened probably about 4 years ago. And I was embarrassed, you know what I mean? And I was like, people started looking around like, what's her problem? Like, what's going on? You know? And I was like, can I just get my popcorn and go? That could be very traumatic for your patient or client. So to role play that of what happens if they get misgendered or what would they say is very important, you know, because they could go home and take their life. That could be it. You know, that was it. You know, I'm being very embarrassed or being outed. What if there was somebody that didn't, you know, was wondering, who are you? You know, what's going on, and starts getting in the mix. It could be very unsafe for a trans person. So I tell you this because you might have done this, or maybe a friend, you might have seen that happen. The best way to do is apologize and move forward. She could have easily said, and this could be in treatment too, "Oh, my apologies. What's your name?" You say your name and then move on. You know what I mean? Instead of make a big deal, because it can be unsafe and it's embarrassing for us and embarrassing for your client. And in a group level, you want to go ahead and keep going and then apologize in private again. And okay. All right. Second thing is passing. If you've ever heard the word passing, it's a term to describe whether or not a person is perceived as a certain gender. And this is huge in the transgender community. You know, so passing as a woman or passing as a man for many trans people, you know, as far as passing as their gender they align with is very important, very well-being, you know. And then there's also passing privilege, which nobody has to worry about passing as who they are, whether they're male or female. And when you can pass, you know, and if you are a trans person, walking white trans, you know, you can also move safely through environments where perceived as transgender is dangerous. So let me give you an example. Like I said, I travel all over the United States. Well, you know, I have to use the restroom, right? So I'm going to have to go into the bathroom at some point. And from the back of me, if you were to see me dressed up in the back of me, oh, it's beautiful, it's snowing out here. You know, somebody could misgender me, have no idea what gender I am. And then also the clothes that I'm wearing, it would be masculine presenting. So, you know, a lot of times, some people might be like, hey, that, might misgender me. So one of the things I like to do is when I go into the bathroom, sometimes I'll take my coat off. You know what I mean? Because thank goodness I have breasts because I can pass. They'll be like, oh, she belongs in here. She has breasts. But I'm telling you these examples for your clients might be going through this. They might have high anxiety. They might go through depression. They might avoid the bathroom altogether. Okay, because they're like, anytime I walk into a bathroom, sometimes people look at me. It could be they could be looking at my hair, but because I've had people walk out thinking that they're in the men's restroom. Sometimes I have a coat, especially when I have a coat on and they can't see that I have breasts. But because of that and working through that, even if they weren't, and say they like my glasses, because it's happened so many times of people walking out, I'm like, no, you're in the right bathroom. That's in my brain. So your client could be that. So are we asking, hey, let's talk about the bathrooms. How's that working? I have that conversation, if they're a trans client, if they're able, are they passing, or, do they want to be perceived as a different gender on the outside or where, and it's not even perceived, that's who they are. It's actually living their best life when they finally do come in full throttle of their social, their physical transition as well too. So one of the things as far as passing, it's important. I mean, one time I think it was at TJ Maxx, I had my mask on and I was looking through what says the men's clothing, even though everything's gender neutral. The genitalia is not attached to any kind of clothes. That's also social constructs. You can wear whatever you like. Men can wear and women can wear dresses. Women can wear pants. Because back in the day, when they did have roles, when the men went to war, before they just had, they would be homemakers at home, some of the women, and they'd wear, their shoes and, their dresses. But then they said, hey, we need to wear pants in these factories once everybody went to the war. And then society says, okay. So a lot of times all these things are built on a social construct of society of what's saying yes and no. So let me tell you about the men's department. I went over there. I had my mask on another time and somebody comes up from the behind and says, sir, do you want, are you finding everything correct? And I was like, at that time in my mind, I was like, I can either correct him and say, oh, my name's Kristina, I'm a woman and, I'm gender fluid, but do I want to go all through that? But this is something that constantly happens. So what I did, I was like, yeah, I'm doing okay. I deepened my voice. I'm doing better. I'm all right. And then he left me alone. So then I didn't have to do that. So you might have people just avoiding as well too, and passing just so they can maneuver. So if you make a mistake, realize your impact, apologize, follow up in private if necessary, but don't over apologize. You apologize and keep going, okay? You also do want to tell your supervisor what happened, because it could be very, traumatic for that person to continue to either get misgendered or use the wrong pronouns, and also commit, to better behavior and then move forward to breaking the habits that, might take time. But at least you'll know to focus and maybe practice in your clinical supervision as well too, okay? So mistakes and saying sorry if you've offended somebody. Let's put our pride to the side and apologize. Well, we don't really mean to hurt somebody, but, forgetting somebody's forgetting somebody's pronouns, using their birth name instead of their chosen name. And a lot of times it's not up to us to be like, well, why did they choose their name? Oh, this is the name that they go by. Once they go ahead and let you know their pronouns and what they go by, then we go ahead and abide by that. If their name is, Bob, and on their form it says Vanessa, well, they go by Bob and they have she and him pronouns or they and Z pronouns, okay? So what else can you do to make you be more of an ally in inclusivity, right? So add your pronouns to your emails would be awesome. And then also you can go ahead and add your pronouns to the treatment facility name badges, but you don't want to force your staff, but you do want to say, hey, I want to open it up, because sometimes people might themselves be a trans or LGBT specific, and they might be transitioning their pronouns too as well. So make it optional, about their pronouns of their treatment facility name badge holder. Also take an ally, which you're taking one right now, trainings, practice suffixes and pronouns, MX, Z, they, X, she, and he. Put LGBT artwork, when you first walk into your facility. Do you have anything that would make, if I walked into your facility right now, what would make me feel comfortable as an LGBT person, a rainbow community person, that I know that I'd be safe? Is there any flags? Is there any kind of historic anything on your walls? Is there a rainbow sticker? Is there trans flag? Is there anything that would say, oh, somebody in here knows something, okay? And think about that. and how would I feel, how, to make you safe? Would your client be safe to say, hey, somebody knows something here? Also, I would have trainings 2 to 3 times a year and update your intake forms on your treatment facilities or anybody doing admissions as well too. Another thing people don't know is about the straight ally flag. So if you are an ally and you want to go ahead and be supportive to us, there's also a straight ally flag you can put up there as well too. Don't mind, we got a guest, a dog in the background. But anyway, straight ally flag, there's also a straight ally flag. But one thing I really want everyone's mind to sink into this really quick is pronouns and chosen names are suicide prevention. Pronouns are suicide prevention. It takes courage for these individuals to grow up and be who they really are. They're really afraid more than anything, to come out and be their authentic self. I would say 70 to 80, if not 90%, somebody that's either trans, non-binary, gender non-conforming has tried to take their life in some type of form, even before the age of 15 to 18 years old. So looking at pronouns or suicide prevention. Okay. So one of the things I want to make sure that you get before you get off this webinar, we still got about 29 minutes, and I'll also take questions at the end, is it is important for providers to understand the 4 concepts of the identity, the core concepts of identity related to gender and sexual orientation. A lot of times people get that confused. And what I mean by that is I want you to think about these 4. Sex assigned at birth is basically when the doctor comes out and, your mother, and also men and trans men have babies too. It's not just mothers. Okay. So let that sink in for a minute, and I'll tell you about that in a minute. But whether you come out of a female, a trans woman, a trans man, or somebody identified as a male, sex assigned at birth is actually when they give birth and they go ahead and the doctor slaps them on the butt when the baby comes out, and they look at the genitalia and say, okay, this baby has either a penis or a vagina or both sexes, which means that they're intersexed. All right. So they either have an eye or they have a male or female. Okay. And then when we looked at, we're going to come down because that's sex assigned at birth. Then you come down to gender expression is how do they express themselves? How is their hair? How is their swagger? How do they hold themselves together? What is their mannerisms, and how do they dress, So gender expression is the other part of how they dress and how they do their hair, how they express their identity as the gender that they are. I'm sorry, the expression is the outside, sorry. And then gender identity, okay, is the gender. So like me, I'm gender fluid and also transgender. Okay, so the gender part is separate than the sex. The sex assigned at birth is female, male, or intersex, okay? Not to be distinguished, needs to be distinguished between the gender identity, because other people might not have a gender saying that they're non-binary. They feel not female or male. Okay. And then you also got sexual orientation. Now, sexual orientation is who you have the hots for. Who are you attracted to? So me, I'm attracted to same gender loving. Okay. So I like to date women. And that's just my thing. That's my sexual orientation. So I wanted to give you the four important core concepts to this. So looking at the gender unicorn, this is something also you can put up as well too. I know if I walked into your facility right now and I saw this, I said, oh, okay, somebody's had a training or even my training, looking at gender identity, which I went over, gender expression, sex assigned at birth, physical attraction, and emotional attraction. Some people only have emotional attraction, which are my asexuals or gray aces. Okay, that's another LGBT term. So looking at other genders, there's also in the Samoan culture, Fafafinas, and in the Native American community, Two-Spirited, which I identify as well too. But this is also something you can put in an office, put it anywhere, and I'd be like, oh, somebody, knows something about gender identity and gender expression. So I tell everybody to go download this. You can Google it. It says the gender unicorn, and you can print it, slap it on your wall. And somebody might ask you questions. I know there's 3 people that came out to the last time I did a training like this. 3 people came out to their clinicians just by having this on the wall, and they had no idea that, the clinician had no idea that they'd even swing that way, you know what I mean? Or, were any way that they swing actually, because sometimes we assume or we don't ask those particular questions. So it's important. All right, so looking at gender, we're going to fly through this part right here, but pangender is a person who identifies with all genders, okay? Then looking at cisgender is when one gender identity matches the gender assigned at birth. So really quick on the call, can a lesbian be cisgender? Go ahead and put in the comments real quick. And I'm starting to see the chat box really quick. Perfect. I'll have to read these too. Okay. So I'm getting some of the messages. Perfect. Yes, absolutely. They can. So if a lesbian can be cisgender, because remember, this is gender. We're not talking about sexual orientation. Somebody that likes women having sex with women, same gender loving, but it's talking about a gender. So identification matches their gender assigned at birth. Then we look at a transgender. When one's assigned gender at birth does not match their internal psychological experience of gender. So first for me, I identify as a gender fluid. And when my fluidity goes more to the more masculine side, because I don't identify as a male, that's when I'm transgender, because it really goes and does not match my internal psychological and physical gender. And I have gender dysphoria, which we'll get into here in a minute. So looking at the third gender, a category that exists in some cultures as well, especially in the Hawaiian and gender, let's see, in Hawaii or Samoan culture as well too, and exist in some cultures where an individual or society determines whether they're not male or female. The other part, which I talked about, which is the Fa'afafine Samoan who identifies a third gender, and then also intersex, which is when an infant is born with ambiguous genitalia, efforts to assign gender at birth becomes complicated. Intersex individuals represent biological intersex of sex and gender. So a lot of times what happened with intersex people, our little kids, is that back in the day, they were like, okay, this particular child was born with both a penis and a vagina. Anything that's as big as my pinky would be a micro penis. And so what the doctors would go and say, oh, well, we can go ahead and operate on your kid. The kid we don't know in their mind what gender we just know the sex, that they have both sexes right now. And the doctors would go ahead back in the day and go do operations and say, hey, we can fix this for you. And then they would go ahead and operate, take away, they would say it's easier to dig a hole than build a pole. So they would remove the micro penis and then open up the little part right here of the vagina. And what they would do is very traumatic to those little infants, is that they would then have poles put there for 4 or 6 weeks as it decided for reconstruction of the vagina. So there's a lot of legislation, especially in California, to leave intersex children alone until they identify and older to make their own decision versus getting their rights taken away when they're smaller. Then you've got AFAB and AMAP. Okay, so acronyms for assigned female at birth or male at birth. The non-binary, which you'll see, which is NB, if anybody puts NB on their stuff, it's gender non-conforming or expansive people. And then you have the gender expansive people for whom the gender binary of male and female just don't apply. And then the gender fluid, which I represent a gender fluid person first and foremost, is people who experience their gender fluid changing in variable ways. Also androgyny, having both masculine and feminine characters. Agender, which is people who had no gender applies, and then intergender, which is another term for intersex, also gender identity that is amongst of the midst of the gender binary of male, masculine, and feminine, feminine and female. And then two-spirited, which I also identify as well too, is a Native American person that both masculine and feminine traits, two-spirited under the trans umbrella. The term two-spirit is an umbrella term across American Indians and First Nation cultures for a person who embodies both male and female spirits within them, hence the two spirits. I say feminine, masculine, because what does a male and female really look like? Because we look like all kind of different. So I wanted to share really quick some examples of LGBT flags. On the left, you've got LGBT flags that was made by Gilbert that has passed away since then. They were struggling back in the day in California. Harvey Milk says, hey, we need representation. So they came out with a beautiful flag, which each color represents. Then you have pansexual, transgender flag, bisexual, the asexual, which you'll also hear ACE, and gender non-binary. Some other ones, we have factions in the LGBT community. We have the leather community, the bear community, which there's also chubby bears. You might have somebody say that they're an otter, depending on a man that is very fluffy and has a lot of hair. And you've got the lesbian community. You also have the ally community as well too. One of the things too, when looking at intake forms considerations, you want to go ahead and take a look at what is the current, when they first come in, what is your current gender identity? Because it could shift and change. Some people don't forget about that piece, and check one or check all that apply: male, female, trans, F to M, M to F, gender queer, gender non-conforming. Additional categories, it could be you could put self-identify right there, or decline to answer. If they decline to answer, don't worry about it. Go back later. Maybe your report, maybe they don't trust you yet. It's not about us, it's about them going through the therapeutic and meeting them where they're at, the process, okay? Looking at also what sex assigned you were at birth, because some people are like, well, what do I ask them? Well, have it on the questionnaire already. Male, female, intersex, or decline to answer. Okay, maybe they don't feel comfortable yet, just telling you. All right, and then what pronouns do you use instead? And I don't say prefer unless they have multiple pronouns. Like me, I have she and they, so you would use prefer. In the very beginning, when you ask their pronouns, you just say which pronouns do you use, because prefer means that it's preferred rather than it is, okay? Then you want to look at defining transgender just a little bit deeper, okay? It basically refers to a person whose gender identity does not correspond with their assigned sex. When we look at the DSM-5, gender dysphoria happens to some people in early life and to others later in life. Mine was actually later in life that happened than actually than a long time ago. So, and sometimes not at all. Not all trans people has gender dysphoria. I just want to let everybody know. I happen to have it, unfortunately, but hey, I work through it. It is an experience of feeling very unhappy as if born in the wrong body or wrong gender or assigned the wrong gender at birth, regardless of body parts. So sometimes people get surgeries. They have top surgeries, bottom surgeries. I was actually going to do top surgery, but I changed my mind because I thought I would go through a grief and loss because I'm so fluid that I hone in my feminine side of me, that I'm so fluid. I would go through grief and loss. So if you have somebody that has the diagnosis of gender dysphoria, please talk to them at a length, because I went all the way up to, they gave me a surgery date. Like I went through the psychiatrist, the therapist, I got all the letters, everything that I needed to, and then changed my mind. And I'm here to tell you, it's okay to change your mind if you're a trans person. And, there might be shame, but you went ahead and told everybody, but also getting that support that, I don't want to do that. I didn't want to go through a surgery that I chose not to go. And I didn't want everybody to be like, oh, now you changed your mind. It's okay to change our mind. I changed my mind. I'm going to keep my breast. It's going to be all right. Matter of fact, it's safety for me when I go into the bathroom. Okay. And not just that part. I just figured I'm so fluid that I would miss them, and I'd go through a grief and loss process. And then, all right. So gender dysphoria comes from a clear knowing about one's gender and a strong misalignment. So being that I'm gender fluid, when my fluidity goes so super masculine, that's when my misalignment of the way I was born as a female comes with my body, and I have a strong dysphoria, when I look in the mirror. So it's different than dysmorphia. Dysmorphia is a different diagnosis for people changing and having surgeries. It's super different. One has to do with gender, and the other one has to do with people excessively going through, sometimes gets misdiagnosed a lot of times for my clinicians and licensed folks out there. So when we're looking at gender dysphoria in the DSM-5, when we're looking at in women, and it's a 6-month duration, it's a strong desire to be the other gender, also a strong dislike of one's sexual anatomy. It could be their penis, vagina, their breast, any of that stuff. We're looking at somebody as little as 4 years old. We're not looking at people that are, kids that are saying, hey, you know what, I wear lipstick, my mom's lipstick, and I walk around in high heels. That's exploring. We're talking about children that says, no, I'm a male. I'm mom, I'm a man. I just have a vagina and breast. I'm a man. I've been a man the whole time. So these are individuals that says, no, I know I am. Versus, hey, I just want to go play and explore, okay? Then when we look at gender dysphoria in adults and adolescents, it's also 6 months, but it fits 2 of the following versus the other one for adolescents is 6 of the following. So a strong desire to be the primary, their sexual characteristics treated as the other gender, also strong conviction that one has typical feelings and reactions of the other gender. So everybody's probably got a DSM-5 that they can go ahead and reflect on this. One of the scales, I'm not going to read through all of this, but a scale when you're diagnosing too is really good. The gender dysphoria scale. On a scale of 1 to 7, you ask your client, tell them to fill this out. I feel terrible when I look at my genitals. I wish my parents let me wear the clothes of another gender. I wish everyone knew my true gender. I would be much more happy if I was the other gender. Sometimes I feel like I'm not even my body, rather outside. Life is like a dream. The reality doesn't feel real at all. Also, changing my body to affirm my authentic gender would make me much more happier. My life is worse because of my gender I was assigned at birth. I felt this way for a while. I think about killing myself because of my body and gender I was assigned at birth do not match my sense of self. My gender is clear to me. Why can't other people get it? So this is one of the gender dysphorias that you can do. I want to introduce everybody to binders. Bandages, some people might come in and they might bind their chest. Why? Because they might have gender dysphoria or they are affected, and the same thing with their penis as well too. But we'll talk about bandages. We don't want to use bandages for binding. It's for compression and not binding. A binder, and I'm going to show you what a binder is, everyone, it's made to flatten the chest so you don't get that dysphoric feeling, with some of the people that have gender dysphoria, to see like there's breast versus it's actually just smooth. For those people, it's an option. For those that don't want to get medically, when we talk about reassignment surgery, or we talk about when someone's waiting for a surgery, this could be taking some of the dysphoric part out of the gender, having gender dysphoria, of having it, close, and it's an even pressure around the chest. It's easy to maintain and clean. It's important. Some people that don't have access to binders, and by the way, talking about binders, everybody should have a resource binder of all LGBT specific stuff that they could utilize when a client comes in outside their office, when, that they can go through whenever they want to, and it should have this information in there, and one of the things is some people that, some clients, they would put duct tape. They were trying to bind it so much, but it was rips and, you get infected, all kind of stuff. So talk to them about that and let them know. And sometimes they might be embarrassed and don't want to talk to you. So it's good just to leave it out in a binder. Like I said, while they're waiting to come, maybe they're next in line, they can look through your resource, your rainbow binder. The top surgeries. So looking at surgery types, depending on how much breast the person has, there's a keyhole, double incision, perimeter, T-anchor. It's just different. And then there's also scars that they put as well too when they take the breast out. So it's important to know this stuff, because your client might say, hey, I had top surgery. Well, what's top surgery? Well, now some people might have gender dysphoria. Some people might not have gender dysphoria. They are aligning their gender of who they are. So taking a look at that part. A lot of people, sometimes they get recommendations, sometimes because they're like, oh, I don't want to see my scars. They get tattoos, really beautiful tattoos. This is what a binder looks like. GTC, and this is no info commercial, but this is one that I know of that's actually made by trans people too, and designed by LGBT individuals in the United States, which is GC2B. And this should be also in your resource binder as well too. It flattens out the chest. There's different colors, as you can see in this person right there. So it doesn't put like there's two breasts that are coming out. Then also for the trans women or men, there's tucking. If you hear the terminology tucking, they tuck their penis back so it can be flat and represent, whether, sometimes people try to pass, like they have a vagina, or some people do drag. Some people have dysphoria too as well, and they might get bottom surgery. So it's important for you to know the terminology tucking. So looking at the trans umbrella, trans man, trans woman, gender queer, this is the umbrella. Gender nonconforming. You'll see that it says male and female, because you might submit some people that say, hey, I'm male. And they straight out masculine, but they might have a vagina, but you might not even ever know that unless they tell you. Okay. But they identify as a male. They might not say I'm a trans man, or they might not say I'm a trans woman. They might already transition and you meet them like that. Also, there's cultural terms like fafinas, which is the third gender, and also the two-spirited individuals. One of the things about considerations, allow trans clients to continue to use hormones in treatment if they are, and also if they're using any street hormones, to make sure that we get the right immediate medical care and legal prescribed hormones. So make sure, like I said, all this stuff, you should already have in a binder. Those that have worked with transgender clients, or if they're a trans man or trans woman, that they're not surprised and cause more trauma when they go to the doctor and say, yeah, we're going to have people with all kinds of different parts. Some people have, went through a medical transition, and also other things. So I just, make sure that you talk to people before sending them and recommending to a medical professional. Looking at self-help groups and case management, providers need to be knowledgeable about the local groups. Make sure you don't send somebody to somewhere you haven't been, and make sure that it's safe for them. And make sure that's affirming, right? So LGBT affirming and cultural specific, and you should have a resource list. Like I talk about, the resource binder should be already available to clients. And if not, make it at your facility, a coming out group, an LGBT specific group that's safe for them to go to. If they're like, oh, it's an hour away, or it's too, we don't do that. Well, make it. You may make it for you. Okay. Encourage shopping around for the right self-help group, and also encourage LGBT affirming sponsors. So one of the tips too, and I see we've got probably about 9 more minutes, tips to be working, and then I'll take some questions, and I'll pass it back to see if Amanda wants to help me fill some questions if she's there. If not, I can maneuver through this. Tips in working with the LGBT coming out process. So planning ahead with them. If somebody comes out to you and says, hey, I want to come out to my father, I want to come out to my mom, I want to come out to my stepdad, my work, where I work, any of that stuff. Plan ahead, test the waters, like the environment. You're going to want to ask them, where would you like to come out? At your work? Would you like to come out, at Pete's Coffee, or some type of Starbucks, or, or a restaurant at Denny's, and the timing. When do you want to timing? The morning, noon, night? And then location. Are we going to Starbucks or what? And then also, if it's school, recovery program, or sober living, is it the right time for them to come out, talk to them? And what I mean by the right time is that they're okay with letting people know when they're coming out, because really that's them. It's not everybody's business, and also safety and support. So say they get kicked out of a program, they become homeless because their parents say, we're not going to accept that, you got to go. Make sure that you have a homeless shelter, or some place for that person to stay safe for a couple of days before you can get them other stuff with the case management part. But really role playing this with your client. Okay, what if it goes good? What if it goes bad? What's the worst thing that can happen? Who are you going to call? So looking at like a safety plan. How when people are on like a 5150 hold afterwards, and then they have to follow up, and safety plan. This is something kind of like that part if something goes sideways. So when we're looking at clinical supervision, that needs to be institutionalized in all agencies treating behavioral health disorders. You're looking at addressing, my clinical supervisors on this call, addressing transference and countertransference issues. Ensure, the staff uses ethical and evidence-based practices. Also, that the staff is not discriminatory toward ethnic or racial minorities. And then regular scheduled supervision, communicate to staff that they're supported and cared about. So when you're looking at the last part, I'm going to talk about traditional treatment approaches with the LGBT population, or I call the rainbow population. MET is, and CBT and art therapy and trauma informed are the 4 best if you're working with this particular population. So looking at motivational enhancement therapy, MET is a style of communication with the goal of helping other clients move toward their own vision and goals by committing to an action or plan. So this can be identified in different stages regarding of their coming out process, their mental health issues and trauma, substance use disorder, and also HIV status and health issues as well too. Looking at this, MET is a direct, person-centered approach to therapy that focuses on improving an individual's motivational change. If everybody's seen the stages of change, it's really like identical, okay? Those who engage in self-destructive behaviors may often be ambivalent or have little motivation to change. So that's important to look at the motivation. Looking at MET, it's the 5 motivational principles. I'm going to go by each one. Express empathy. You see the little cat down there, therapists creating a supportive environment to help the individual. Develop discrepancy. So the therapist directs attention toward the discrepancies between an individual's desired state of being and that individual's actual state of being. Number 3, avoid argumentation. You see my raccoons down here? This fits perfect because it's like totally snowing out there. A therapist will avoid attacking an individual or individual's behavior, as this is thought to result in defensive and resistance. Then you got roll with resistance. I think that's a horse or a donkey, and we know about rolling with resistance as far as instead of directly confronting and any resistance on the part of the individual, the therapist tries to diffuse it, often reflecting, listening, or simply going along with what the individual said. And then self, you see my frog, time for change, self-efficacy, one's motivation to change typically depends not only on the reason for the modification behavior, but also the beliefs that one is able to perform the task required to change. So looking at cognitive, switching gears, cognitive behavior treatment family therapy, the CBT-FT is following, you should utilize this if you have any family therapists, people working with families. CBT-FT is great, using following a child's coming out or an adult's coming out. Topics are that you can have after, the family adjust is parents' attitudes, beliefs, and expectations are explored without them being in the room. Increasingly more silence topics are described and discussed, and also about specific listening and problem solving. Enhancing the family communication is so important as well too. Then, I know we got 4 minutes. Here we go. Art therapy with the LGBT or rainbow community clients. This is so therapeutic. We got to do it. This right here, I'm going to give you art therapy with the clients is, it's really great. Art therapy and counseling with the rainbow population, especially during the coming out process, was associated with an increase in emotional and physical well-being. So growing evidence in support of use of personal creativity and expression and sexual identity. So I'm going to give you an example, and I'm going to give you, before we wrap up today, is an example of an art therapy activity is the inside and outside of me. Okay, so make sure that you can get any kind of crayons, pastels, draw with their hands, pencils, all the above, anything to do art. Okay, and it's called Inside and Outside of Me, and instruct the client to create 2 self-portraits. The first one would be the portrait of publicly representing themselves, which is all of their outside. And then another portrait of privately internal self of them inside. You will see there is 2 separate ones most of the time. And clients in stages of coming out might have 2 very different portraits of what they are inside. I've seen people come out with flags and shooting rainbows, and then the outside is like this person that looks like they have glasses, and they're all perfectionists, and so we get to talk about it. It's great for your SOAPy, your DAP notes. You can keep talking about the outside and the inside, and really go on a deep dive if you're a therapist, if you're a clinician, if you're a counselor, staying in scope of practice, that you want to stay on the here and now. And then if you're a peer, about the coming out, you can do technique versus therapy. You're not going to go deep dive, but you can also stay the technique of the art of making different are having the activity done. So these portraits can be used as discussion and reflection, okay? And then the last thing I'll say before I take questions is trauma-informed care is very important. A program, organization, or system that is trauma-informed, anybody working with the LGBT rainbow community wants to approach it with a trauma-informed lens, okay? Realizing the widespread impact of trauma and understanding potential paths for recovery. So recognizing the signs and symptoms in a client, families, staff, and other, trauma policies, procedures, and practices, and only seeking to actively assist re-traumatization. You don't want to re-traumatize. Everybody should be getting this particular training. So with this, I'm going to go ahead. I've got probably 2 minutes. We made good time, and open it up for questions. If anybody has any questions for me, we'll go ahead. I'm going to go backwards. I'm going to end the slideshow really quick, and then I can open it up and see everybody's beautiful face. Okay. All right. So I'm going to go ahead and bring Amanda also here with me as I go through these questions. Amanda, are you there? I see you.
I am here.
All right.
So
do you mind?
Yeah, let's do, go ahead and use your raise hand feature if you have questions, please, and then I'll have you unmute and we'll go through them.
Yeah, and I think there's some already in the chat box. If you don't mind reading those, that'd be amazing.
I do not see.
I think there was some, and there's some comments too as well. And if not, I can go ahead. I see there's a comment right here that says, I'm a heterosexual lady and I used to duct tape mine down in college because they were massive. I'm now a G cup. No, nothing works now. Okay, so yeah, these particular binders too could help as well too. And then some people also get reduction, which is different than just top surgery altogether. I went ahead and, oh, whoops, I put the wrong phone number, sorry, 653-18. This is information if you want to get a hold of me, 650-653-1854, or contact me at Kristina.Padilla at gmail.com. Anybody else have any questions? I mean, Foundry brought me here to, other than that, I do consulting as well too. All right, I don't want to mess up your name, Shahin, beautiful name, by the way.
It's Shahin.
Shahin.
Shahin means falcon in Farsi.
Farsi, beautiful.
Yes. I came today. I was very happy to get the email because I wanted to learn more about all these changes that are happening and is very rapid changing in this community of the rainbow. I'm a psychiatrist. And I think that I can learn a lot from people who are, based on the non-binary movement and the gender fluidity and everything that you said, opposing the oppressive social imposing roles, the roles that are imposed upon all people. So that's what is happening right now in the country. And this Rainbow Coalition is also in front of that. So it's not just, to me, it's not just that it's very important for the individual to stand up for what they choose to be seen or called or their preference, but at the same time, they're opposing oppressive systems in the society. That's the leadership I see in this community, and I'm so glad I came here to learn from you.
Awesome. Well, we're very happy to have you. So thank you so much for your comment as well.
Sure.
Thank you. All right. Is there anybody else before we close up for today? It's been really awesome hanging out with all of you this morning and, really getting some great.
One more question.
Sure.
You talked about all these terminologies, but you didn't talk about transsexual.
Transsexual is a very outdated term.
Yes, and how did it become outdated?
It came outdated probably like 5, 10, probably I would say about 10 years ago. But the thing is people still use it. They still use it when, especially like in the DSM-5, when people have if you see on the DSM-5 that there's 2 in there right now that has the dysphoria, and then the transvest. It's like a person dressing up, which I believe should be taken out as a professional, because unless it causes impairment, it shouldn't be even in the DSM-5. Some people do have fetishes and all kind of stuff that doesn't have nothing to do with impairment. People dress up in each other's clothes, and what really defines, the feminine and masculine clothing of what that is. Remember, but if it's causing impairment, yes, I'm on board for that. But no. But the other part of when we talk about transvestite, it's more used like derogatory, shall I say? Not always. People do still use that because that's actually, like I said, it's in the DSM-5 and a lot of what is it called? A lot of writings people use that. But the long story short, it could be offensive to some clients. So I don't know if there was anything else in regards. I was trying to you were asking about individuals, when they talk about being that, people dressing up in clothing.
Because some people think that it's the sex that is important for me that needs to be changed more than what the gender that I am. Gender as a social role is important, but for me, for example, I feel like my body, I'd like to change my sex. Like when the focus is on changing the genital area and the sex more than what comes out.
Well, yeah, and one of the things when you look at, as far as like the difference between like transsexual, it says denoting or relating a transgender person, especially one whose bodily characteristics have been altered for surgery. So a lot of times, when we look at both, the transgender is the umbrella term that describes who have a gender that's different, from the sex assigned at birth, versus transsexual is more specific term that fits under, which it does still fit underneath the transgender umbrella, but it's just more affirming to say transgender than transsexual because it's outdated.
Okay.
But people still use it. Okay. But if somebody called me a transsexual, I would be offended, to be honest. But I would roll with it because guess what? That's my stuff. And I knew that to be derogatory and outdated. I'd be like, hey, can you just say transgender? And then I'll just correct them and then we'd move on. But before it was derogatory, saying, look at that transsexual all worked up and wearing whatever they're wearing. You know what I mean? So it was really derogatory. But like I said, it would really be person-centered of who, it's our baby boomers and, back in the day that they utilized that term, and it's still being written as well. All right. Any other questions that anybody might have? Everybody's quiet. I don't even see anyone's face. Okay. It's all right. Well, if you think of anything else, let me know. I'm going to pass the mic back to Amanda. Thank you so much, Foundry, for having me. I really appreciated this time. Link in with me on LinkedIn. Would love to see you. And all right, back to you, Amanda.
Thank you so much, Kristina. I posted down at the bottom of the chat is an evaluation for this session. And once you fill that out, give me about 10 days and I'll get your CEs out to you. I believe everyone has my email. Please feel free to contact me if you have any questions that maybe, might come up later today that we didn't think of at this time. And thank you again, Kristina, for coming all the way out into this blizzard that we have in Steamboat.
Oh, I love it. I love it so much. You know what I mean? I'm so excited about this blizzard out here. I'm from California, everyone. So California, I see it's snowing out here and I have a little girl that's 5 years old. So I made her a video. So thank you so much for having me. I really appreciated my time here and look forward to connecting with all of you later.
Thanks, everyone.